So thanks again, everyone, for coming here. Quick question before we get started. How many of you are sick and tired of hearing about AI and ChatGPT and machine learning? Well, too bad. Welcome to my presentation on the next generation of AI solutions in patient access. Okay, so I do, on a serious note, do believe that I think what we're experiencing today is true disruption in technology with what's happening in AI, with the large language models coming through, and the potential use cases where we can use technology like that, including in patient access, could be something very valuable to healthcare providers. So that's typically what this presentation is about. I think we're going to look at the genesis and evolution of work, how work was traditionally done, how healthcare providers are doing work today, and how we can incorporate some of the latest technology into increasing efficiency, cutting costs, and really, providing better, more seamless and reliable patient access to care. So, I represent Infinx Healthcare, and Infinx has solutions throughout the spectrum of revenue cycle management. I'm going to focus on the pre-care side of revenue cycle management, the patient access side, really, starting from the intake of orders to verifying if the patient has insurance, checking what the patient estimate is based on the benefits, and then, of course, addressing the beast of patient access, what I call it, prior authorization, right? There's other use cases here too, if anyone's interested in any of them, happy to talk about them after my talk. I'm sure people here are familiar with the challenges, but what we're really trying to do with solutions is address those significant administrative costs, right? How do we make sure that human effort is lowered? We can get patients' care faster and not have to wait for high turnaround times, waiting for prior authorizations, waiting for a payer to answer a call, to respond back to additional information, to do highly arduous manual tasks like taking in referrals, entering into EHR, EMRs. And then, of course, this is all about also reducing your claim denials, right? Having less write-offs. It all starts in the front end, right? You tackle these problems in the front end, your life is going to be a lot easier in the back end. Constantly changing payer guidelines, right? I think knowing what even requires an authorization, what doesn't require an authorization, what's going to get approved once the auth has been initiated. How do you avoid that back and forth with the payer, where the payer asks for additional clinicals, additional information? Can we intercept that? Can we make that process more seamless? So let's look into that. So, the slide is titled Genesis of Work in Patient Access. So really, I think in more than one way, this mimics other industries as well, where you have a lot of manual work take place, a lot of manual data entry, calling, where to check if a patient is eligible with their insurance, know what the benefits are, initiate a prior authorization. You have to go on to figure out what the right portal is, do a bunch of manual data entry, or worse, pick up the phone, call payers, and just spend a lot of that time just waiting for someone to answer. But then a lot of healthcare providers got tech savvy, over the last 10 years. You've heard this term over and over again about the digital transformation that healthcare providers have tried to, indulge in. And, that has brought out process efficiencies. Things have gotten better by making systems more interoperable, by introducing things like RPA, which is robotic process automation, where either working with vendors or providers themselves have been able to automate some of these tasks that involve, say, data entry on portals. and then communicating with other systems through HL7 rather than having someone manually export files and import them. So, things have been good, but we can make them better, right? And we do that through, I think, the AI part of these things, right? Through the machine learning and clinical natural language processing. That's NLP, which is essentially the ability for AI to read, understand, comprehend unstructured data, text like patient charts, physician progress notes. And we'll talk about the use cases. How is it applicable? How is it beneficial for providers? So let's look at each use case one at a time. Let's start from the very beginning, right, which is referral intake. The problem here is that, unfortunately, there's still a lot of faxes, right? Especially for outpatient providers, they get a lot of faxes from a myriad of different sources. They have fragmented ordering physician markets that, there's no standardized form the way that referrals come in. So they have to deal with, varying formats of faxes. And then someone has to look at them. Someone has to manage them, enter them into the EHR, EMR, RIS. And again, just very manually arduous process. A lot of providers, when I talk to them, say that, hey, we're trying to implement a referral portal. We're trying to have our physicians send us referrals through this portal. But again, very low adoption there still. So there's technology currently that helps with some of this, right? I think OCR, some solutions incorporate OCR, but again, OCR is very limited in terms of looking at unstructured data. So if you have patient referrals that, even have patient information on the left-hand side and physician information on the right-hand side, OCR is unable to process that. OCR is good at looking at text and just converting that into a digital format, but a lot of things can throw it off. So if a physician information and a patient information is next to each other, OCR will just read it as the same thing, right? It doesn't have the ability to understand that, hey, this is patient information, this is physician information at a very basic level. And I think what AI, what natural language processing brings is, of course, better structuring of that data, but also contextual awareness, right? Which is the ability to understand that, hey, just because some pain is mentioned somewhere, does that mean the patient has that pain, does not have that pain? What's the severity of that? Is that related to any other diagnoses? Are there contraindications involved? I think the contextual awareness is something that natural language processing is developed to understand, and I think that's where we'll make the most headway once these NLP models, especially things like ChatGPT, get better at understanding the clinical and the medical domain, which is, I think, what companies like Infinx are doing, really tailoring these language models to understand the medical and the clinical domain. And then what we do then, Infinix has a referral intake solution. What we can do is, it doesn't just help to have a solution or an AI look at a referral and extract all information from it, like patient details, physician details, ICDs, CPTs. If someone still has to take that and enter it back into the EHR, what we do is we can send back an HL7 and ORM message that can just automatically create a new patient or an order within the provider system. Okay, let's get to financial verification, right? Insurance verification, benefits. So the problem today is, again, too many. Every home plan has its own portal. You have to figure out what the right portal is. You have to call in order to get custom benefits. A lot of portals will give you a set of standard benefits. But if you want custom benefits, if you're looking for more details than what's provided on the portal, you're going to have to end up calling. If you use, I think the standard here is EDI 270, 271. If you try to automate this, that's even more limited in terms of the information you get with a high level of variance from payer by payer. So you'll get your deductibles, your out-of-pockets, your copay co-insurance. But if you want to know if a referral is required or not, if you want to know if an authorization is required, how many visits are covered, you will face challenges very quickly. And then, of course, checking eligibility or lack thereof is one of the biggest reasons for claim denials downstream. So what happens today, again, checking on portals, calling, using solutions that do this EDI 270, 271. But I think how we get better is incorporating, again, the intelligent piece here, right? Which is even the robotic process automation, bots that we can build to go onto web portals, to look at data, we can make them more intelligent. A lot of portals are getting smarter in terms of recognizing humans versus bots. Famously, Optum portal will now have verification to try and beat this. So, solving the entire problem associated with financial verification, there are tools that AI offers us to help this. I think I've talked about insurance discovery there. The problem of self-pay patients where about 9% of the entire patient population today is supposed to be self-pay within the country, right? So the interesting thing is that almost anywhere between 30 to 50% of them actually have some sort of coverage, right? So as a provider, you can know that there's some billable coverage for that patient population. Can you increase your odds of collection massively? So insurance discovery, again, leverages artificial intelligence to figure out where is that hidden coverage. Does that patient have some sort of government coverage through their spouse, so on and so forth. And then we get to prior authorization, right? I've divided prior authorization into a couple of slides, and we look at the different challenges within prior authorization. Prior authorization as a process, at Infinix, we break it down into 3 steps, which is first determining whether prior authorization is even required or not. If it's required, we initiate it with the specific benefit manager or home plan. And then once it's with the payer, sometimes you can get the immediate approval, but a lot of times you have to chase the payer, and then we call that following up, checking the status, and then obtaining the authorization. If there's any back and forth required, if the payer needs additional clinicals, that all of that falls into the follow-up process. So determination, initiation, follow-up. So let's start with the first one, right? Determination. Is it even required? We have a lot of healthcare providers that, struggle answering the question or knowing what requires authorization because, again, of the ever-changing guidelines, and then just, I think, the opaque nature of the guidelines themselves. Knowing whether it is you check determination through the benefit manager or through the home plan. I think this is another big problem that we see, which is, the benefit manager might say no auth required, but then there's a denial because the home plan says, hey, auth might be required, you never checked with us. So there's interesting problems even in this phase of the authorization process. Current solution involves, following the same track, checking on web portals. There are vendors out there that can do some bot automation, but again, very, very limited automation in the prior authorization world today. So what we have done to address this problem is build a machine learning model that can essentially determine with a very, very high degree of accuracy whether an authorization is required or not. So we leveraged, we've been in the prior authorization business for a long time, and we've seen a lot of data, so incoming data, what requires authorization, what doesn't require authorization. And then we've leveraged that to essentially build a machine learning model that can predict whether an authorization is required or not, and it works at levels of over 98.5% accuracy. We've built it to be conservative so that when we're unsure, we don't make a determination. We only make a determination when we're very sure. So the benefit of this is it's real time. You can instantly know whether an authorization is required or not. The value being that you can then schedule the patient right away. You don't have to wait. The next one is, say, auth is required, and then we want to initiate it with a specific entity, the benefit manager or home plan. How do you know when it's going to be approved, right? You want to schedule the patient. Do you take the risk of scheduling the patient and then maybe the auth being denied, or then do you risk just not scheduling the patient and the patient perhaps going to another provider? So again, this problem can be solved where, at Infinx too, we've built a machine learning model that, again, has looked at various entities, various payer response times based on the types of cases that we're seeing. And we can tell you essentially that, hey, the authorizations will be obtained in this amount of time, so that you can, with a higher level of confidence, go ahead and schedule the patient for that day. And again, the value here varies by specialty. For radiology, you'll see that a lot of authorizations get approved faster, but for other specialties, it does take longer. We have authorizations for labs that can sometimes even take weeks. And then I think my favorite use case is essentially, will it get approved, right? So there's a lot of guidelines, a lot of criteria that have to be met for the prior authorization to be obtained. And, a lot of times you will get the prior auth obtained, but I think the margin of error is so small that for the percentage that do get denied or that go into peer review, I think there's a lot of value to be untapped in just overcoming that population. So, as I've said there, right, this really here is the true bottleneck to complete automation in prior authorization, because this involves looking at the patient's clinical history, the physician progress notes, which is not something that, bots or any other form of automation, traditional form of automation today can do. Automation today can initiate a case with a payer if there's the right connection there. It can follow up, if you have the connection with the payer or through bots. But, to initiate a prior auth request where you have to, say, answer clinical questions or know whether the patient meets criteria for that specific payer or benefit manager's guidelines is, I think, the tricky part of prior authorization today. And like I said, there is no current solution, right? So, if you can, even the best vendors out there today, you can automate the rest of the prior authorization process, you will still need someone to look at the patient's clinical documents and then answer the clinical questions that are presented by the payer. Or even if a clinical survey is not presented by a payer, you still want to know if the case meets clinical criteria for that payer in order to know whether the prior authorization will be obtained or not. So that's where, again, I touched on this before, the clinical natural language processing piece comes in, where, the AI can look at that patient's clinicals, no matter how unstructured that data is, match it against that payer's guidelines, and then tell you with a level of confidence that, hey, this will get approved or this will get denied. The value there being, again, that you're not in darkness in terms of what gets approved, what gets denied. If we say something potentially can get denied, the solution will have the ability to tell you why it would get denied. Hey, it doesn't meet criteria X, Y, Z from this payer. So you can then go ahead, talk to the physician, see if that criteria is met or not. And, this is something that, we're very proud of, that we're building right here, where essentially the process involves extracting those key clinical components from patient clinicals, extracting those key components from the payer guidelines and then really being able to match it together. The intention here being to augment the intelligence that a prior authorization specialist would do so that they can then look at it and be like, hey, this makes sense, all good. You would still require some sort of an audit process, but the process would just become way more streamlined. So with that, I think we're at the end of the presentation. Thank you, everyone. I'll take questions if there are questions. Hey.
So at your clinical natural language, how does that work for like urgent requests? So if I have like a symptomatic patient that we're trying to get in urgently, how do you work with payers in those instances? Like, because it doesn't obviously say urgent, or is it pulling out certain symptoms, or is it something you can go for and diagnose? How does that work?
Sure. So traditional urgent care, again, emergency care, typically would not require prior authorization, but yes, if it's an evaluation and you deem something you want to fast track, I think the value here is that with traditional forms of doing this, you would have to manually do this. You would send it to the payer. You try to tell the payer, hey, can we expedite this? We want to do this. You really try and avoid that whole process here because what we're trying to do is we're trying to even work with the payers with the solution here where we can tell them that, hey, we're submitting this authorization request. We've already done the clinical checks. It meets your guidelines, and then the payer can just be like, hey, everything's good. So I think right now the value is that the submission part of it would be a lot faster. I think there would still be need for telling the payer, hey, we need this expedited. But I think where we're going with this is the payer, once we establish those payer relationships, the payer then is just like, hey, I think they've done the check. And then we can just approve it instantly.
So with those payer guidelines, what does that setup look like? And who kind of would you own, would we own as a facility, and making sure that payer guidelines change?
Right.
So is that a collaboration effort? How do you maintain those payer guidelines? Is that something that's kind of built into this AI? Is that something that's built into their EHR? Because some people have some matrices built into their EHRs. There's some sort of easy features and so forth. So how does that affect?
Right. So our solution handles that. I think that's a component of the solution where we make sure that and we're dealing with typically multi-specialty and a lot of different specialties. So within those specialties, anytime that payers make changes, we have a team of, it's part of the AI. AI is constantly scraping for changes, but we also have prior authorization specialists that are conducting these reviews in the back end. So if there's anything custom with a specific facility that we're working with certain payers that we don't have enough experience with, then we collaborate on that. But for most, I would say for most payers, we keep an eye out on the change and we're up to date with the guidelines. Any other questions? Yes.
The HL7 message is coming from the scheduling system or from the API?
What was the other one? I'm sorry?
The HL7 message, are they coming from the scheduling portion or from the API?
Right. So I think that varies by provider and provider. So for prior authorization, typically it depends on when you want to get that authorization. So if you want to do it at the point of scheduling, then HL7 has an SIU message that you can send us. Typically, ADT is with the patient visit. It ends up being too late to do the prior authorization at that time. So we recommend that the ORM, the order message, or at the point of scheduling, the SIU be used. But if you want to do insurance verification checks, at the point of patient visit, I think you can do the ADT because that's more real time. We can just tell you that, hey, patient's eligible, all good. Prior authorization can take a little longer, so typically advise not to do ADT.
The elective procedure perspective,
Mm-hmm.
so the system capture, let's say, is required for a normal ride. Does it capture that there's already an authorization in the system?
Right. Yes. Yes. So typically the payers, when you go to initiate an authorization, the the payer portal will tell you that there is an authorization on file. Sometimes what happens though is it may be for a different facility or from a different physician, so we communicate that to you and then ask you that, hey, do you want it reinitiated, a change, or does this work? Yep. No problem. Anything else? Anyone? All right. Cool. Thank you for attending.